Aloha and welcome to week 10 in cardiovascular health. This week's lecture is on valvular diseases. So at the conclusion of this lecture, you should be able to differentiate between the different types of valve disease. So congenital, acquired, structural, and infectious. Understand risk factors for valve disease. Differentiate between regurgitation and stenosis. Risk factors, signs, and symptoms, and common heart valve disease treatments. Now, valvular heart disease encompasses a number of common cardiovascular conditions that accounts for 10 to 20% of all cardiac surgical procedures. You'll no doubt in practice see patients and they'll say, oh, I've got a leaky valve, etc. Then the big question is, you'll know the severity based on how often they're going in to get echo Dopplers done, etc. Degenerative valve disease is the most common form of all the valvular diseases. However, rheumatic heart disease accounts for the most valve pathology in developing nations. Now, valvular heart disease affects 1 to 2% of young individuals. So exercise in patients with valvular heart disease requires a structural approach, which includes do they have any symptoms, their exercise functional capacity, the type and nature of the valvular lesion, the impact on ventricular structure and function, and the effect on the pulmonary artery pressure. Now, generally, in a report, you might see, if it's from a GP, that they say the patient's got, an enlarged left ventricle. And if they've got an aortic stenosis, then you'll know that that's related to enlargement related to the aortic valve problem. If they say the left atrium's enlarged, then you know it's a mitral, or it suggests a mitral valve problem. Now, asymptomatic individuals with minor valvular abnormalities can engage in all forms of competitive sport and exercise. If it's moderate in severity, the exercise may exercise intensively if a stress test reveals good functional capacity without ischemia, any hemodynamic disturbances, meaning that they have a normal blood pressure response, or any arrhythmias. This Gaddy paper last year from the British medical journal Heart is uploaded in this week's chapter, in this week's Blackboard. Now, symptomatic athletes and patients and those with severe valvular heart disease, impaired function, pulmonary hypertension, and arrhythmias should refrain from most intensive exercise. So if it's significant aortic stenosis, refrain from resistance training exercises or pulmonary stenosis. Now, you must monitor the exercise intensity, and the patients or clients have to stay within the recommended heart rate training zone that you set according to guidelines. Now, the prevalence in Australia of any valve disease is approximately 1%. And of those with a valve disease, less than 0.5% have aortic stenosis. The prevalence of moderate or severe aortic stenosis in patients more than 75-year-olds is about 2%. It's the most common valvular heart disease of the elderly, and it increases with age. And it's not surprising, actually, because with everything, we see deterioration with aging. The prevalence is about 2% at 75 years, but it more than doubles at 85 years of age. Now, what about aortic stenosis? In valvular heart disease condition, valvular stenosis, the tissue forming the valve leaflets becomes stiffer, which narrows the valve opening, thus impairing function, and therefore it reduces the blood flow through it. I'll put up a brief video to show you what I mean by aortic stenosis. Sorry, let me just bring it up to the front, and I'll see if I can get that any bigger. Yep, that'll work.
Aortic stenosis is a heart valve disease that affects as many as 1.5 million Americans. It becomes more common with age, affecting 1 in 10 people over the age of 75. Left untreated, severe aortic stenosis leads to decreased quality of life, heart failure, and even death. Aortic stenosis occurs when the aortic valve, the main outlet for blood being pumped from the heart to the body, becomes abnormally narrowed. In older adults, stenosis is typically caused by wear and tear and the gradual buildup of calcium deposits that stiffen and narrow the valve, keeping it from opening properly. As the valve narrows, the heart has to pump harder to push blood throughout the body, and this can lead to symptoms like fainting or nearly fainting during exertion, chest pain, weakness, and fatigue. While not all aortic stenosis patients experience symptoms, 3 out of 4 older patients with severe aortic stenosis do. However, many dismiss these warning signs as normal aging. This often leads to the underdiagnosis of aortic stenosis. Those that experience aortic stenosis symptoms have diminished quality of life, making everyday activities like climbing stairs and walking increasingly difficult. If you are medications can treat chest pain or other symptoms, but none can reverse aortic stenosis. Only repairing or replacing the defective valve will eliminate aortic stenosis. Without surgery, 50% of patients with severe aortic stenosis don't survive more than 2 years after the onset of symptoms. Aortic stenosis treatment typically requires aortic valve replacement surgery, or AVR. This surgery replaces the defective valve with a mechanical or tissue valve. AVR improves quality of life and increases survival in most patients. But
now, as you saw in that video, the leaflets become narrow. That's what stenosis means, reduces the blood flow. If the narrowing is mild, the overall functioning of the heart may not be reduced. However, the valve can become so stenotic, so stiff and closed, that heart function is reduced, and body blood flow out of the left ventricle up through the aorta may not be adequate. Now, on the ECG, it's usually associated with left ventricular hypertrophy. And the reason for that is because the left ventricle is having to work so hard. However, it's not a reliable test. Echo Doppler is what's used to identify and determine the severity. So what they do is they look at the jet velocity, the mean gradient, and the valve area. So when they look at jet velocity, they can actually measure this on echo Doppler, and it's a non-invasive, very simple test. Now, it's a well-known cause of exertion-related sudden cardiac death, so that's why it's problematic for you with patients, and it's responsible for 4% of sudden deaths in young individuals. Now, with severity, we spoke about that. It's usually defined as a mean gradient greater than 40 millimeters of mercury and a peak jet velocity greater than 4. You can see mild, moderate, depending on what you look at. And here you can actually see this is from a Doppler study, and you can look at how you measure that. And the new machines that are out, are quite simple. They just basically trace the outline, and it gives them all the measurements. Now, what about valvular insufficiency? So that's the so-called leaky valve, and it's also called regurgitation. So when blood flow is supposed to go, let's say, for example, from the left atrium to the left ventricle, and the blood's supposed to only go one way, the valve closes, and no blood should go retrograde or backwards into the left atrium. When it's leaky, or i.e. regurgitation or incompetence, that's when it's going backwards where it shouldn't go, and that can occur at any of the valves. So basically, when the leaflets don't close completely, it allows that retrograde or backwards blood flow across the valve, and that's what regurgitant flow is. So you may see that actually on reports, and it's the severity that's important. Now, congenital valve disease develops before birth, hence congenital. Common problems that cause this type of valve disease are abnormal valve size, leaflets not properly formed, or an abnormal leaflet attachment. This most often affects the aortic and pulmonic valves. Now, bicuspid aortic valve disease is a type of congenital valve disease that affects the aortic valve. The valve has 2 leaflets, or what's referred to as cusps, instead of 3. And because it doesn't have that 3rd leaflet, the valve becomes stenotic or leaky just because it can't close all the way. So if you look at the valve on the left, you can actually see how it closes, looks like all the way. But if you look at the one on the right, there's a gap, and that gap allows the retrograde flow of blood. And GP1 echo Doppler is clearly the way to do that. But this is what doctors can hear when they listen with a stethoscope to the chest, and they put it over the valves. Now, acquired valve disease, it affects normal valves. It can be the result of an infection, meaning either endocarditis or rheumatic fever. It can also be caused by the change in the valve structure, i.e. if there's stretching or tearing of the chordae tendineae or papillary muscles. It can also be due to fibrocalcific degeneration or dilation of the valve annulus. Let me go back up so you can get a picture of that. Hang on. Okay, so here's a picture, and this illustrates, you can see the papillary muscle and you can see the chordae tendineae. So what they do is they go from the papillary muscle, which connects to the heart wall, to the valve. And what happens is if they stretch, that means the valve is going to be loose. So the problem can occur either at the chordae tendineae or at the papillary muscle. Now, rheumatic fever, it's a common cause or type of valve disease called rheumatic heart disease. It causes the heart valve leaflets to become inflamed. So they may stick together and become scarred, rigid, thickened, or shortened. And because of that, you get retrograde flow of blood. One or more of the valves, most commonly the mitral valve, may become stenotic or leaky. Rheumatic fever is usually the result of an untreated streptococcal infection, i.e. strep throat. So the use of penicillin to treat strep throat can prevent this disease. The valve itself is not infected when you have rheumatic fever. Instead, the body produces antibodies to fight the infection, and it's those antibodies that react with the heart valves, causing the inflammation and eventual scarring. Now, infective endocarditis. So it's also called bacterial endocarditis. It can be called subbacterial endocarditis. It's a life-threatening infection of the heart valve or the heart's inner lining, meaning the endocardium. It occurs when germs, specifically bacteria, but occasionally fungi or other microbes, enter your bloodstream and attach to the surface of the valves. In endocarditis, germs attack the heart valve, causing growths on the valves. It can cause holes in the valves or scarring, results in the leaks because of the stenosis. Now, structural heart valve disease. So can occur either for acquired or congenital causes. So we spoke about stretching or tearing of the chordae tendineae or the papillary muscles. So again, remember, this is the papillary muscles, this is the chordae tendineae, that's the valve. It can result from a heart attack, a valve infection, and again, the mitral valve is the most commonly affected. Now, mitral valve prolapse. This is caused by weaker than normal connective tissue in the mitral valve. And what happens is when the valve closes, so you've got the left atrium, you've got the left ventricle. So the valves go forward into the left ventricle when the blood is ejected from the left atrium. And then the valves close. With mitral valve prolapse, actually the valve leaflets go back into the left atrium and it allows retrograde flow. So the tissues become stretchy and that's why it goes back through. Now, these are recommendations that are out. So although it relates to athletes, it also can be used with patients. So for example, if somebody's got mild mitral regurg, really they can do anything. If it's moderate, then you can see that they can participate depending upon the pressures. However, if it's severe, and you can see it for mitral regurg, mitral stenosis, aortic regurg, and aortic stenosis. Now, what about aortic stenosis? So it's one of the most common and most serious valvular disease problems. It's a narrowing of the aortic valve opening, which restricts blood flow from the left ventricle up through the aorta, but it can also affect the pressure in the left atrium because it backs it up from the left ventricle into the left atrium. So aortic stenosis can result from congenital heart, called a bicuspid aortic valve, and this condition more commonly develops during aging as calcium or scarring damages the valve and restricts blood flow through the valve. So what are symptoms of aortic stenosis? So dyspnea or breathlessness, angina, syncope, which is fainting, palpitations, a decline in activity level or reduced ability to do normal activities that require mild exertion, or a heart murmur. Aortic stenosis is one of the most prevalent forms of cardiovascular disease in the Western world after hypertension and coronary artery disease. It's either caused by degenerative calcification of a trileaflet valve or progressive stenosis of a congenital bicuspid valve. Aortic stenosis develops from that progressive calcification of leaflets that end up with a restriction in the leaflet opening over time, and hence that's the stenosis. So risk factors for aortic stenosis: diabetes, that means type 1, type 2, hypertension, smoking, elevation of LDL cholesterol. Now, don't worry about that. Now, what about heart disease treatments? So let me bring up this video.
It's helpful to have a general knowledge of what the treatments are for valvular heart disease. And they can fall into 4 different categories. So let's start with number 1, do nothing. And do nothing isn't really do nothing. It's a program of surveillance that a doctor may lay out. Maybe that valve isn't bad enough to do anything right now. It's leaking a little bit, but the treatments aren't benign. They carry risks. And if the risk of that little bit of leakage is less than the risk of the treatment, surveillance, we do that for a period of time. Some valve disease can be treated with medication. This tends to be when a valve's leaking rather than when it's blocked. So if a valve is leaking, there are medical therapies that we can put a patient on and treat them with medication for a period of time that's combined with surveillance. And under medical therapy, the heart can get stronger. We can alter the loading conditions, lessen the amount of leakage of that valve, and allow the heart to get stronger or go longer before we need to pull the trigger to intervene and do something about that valve. Now, if we're going to intervene and do something about that valve, traditionally that thought has been surgery. So let's talk about surgery first. When we talk about surgery, that can fall into 2 broad categories. 1, fix the valve. 2, replace the valve. And those have different implications. If we're talking about aortic valve disease, we are just now entering the realm where we're starting to fix more and more and more aortic valves. But for years, and still prevalently, the treatment is replacement of the aortic valve. The mitral valve is a much more complex valve. A lot of different things are controlling whether or not that mitral valve leaks or is blocked. So repair plays a much more prominent role in the mitral valve. We can put rings on that lessen the diameter so that the leaflets can now meet in the middle again instead of meeting out here. If it's a problem with the chordae tendineae that's broken, we can replace that. We have a lot of repair techniques for mitral valves. If one part of the mitral valve is badly destroyed and the rest is working, we can actually take that part out and repair the rest so that it comes together. How we get to the valve to fix it frequently gets confused with the fix itself. And there are 2 different issues. The principles of repair and replacement stay the same, whether you access that valve through a median sternotomy, which is an incision through the breastbone, a small incision between the ribs over on the side, which some people might call port access, whether you use port access and you use a robot to help you throw the stitches. Those are all matters of access, not matters of repair or replacement. So don't confuse those 2 things. issues of access have to do with short-term healing. Maybe a smaller incision heals faster than a larger one. Maybe one hurts less than the other, but they have nothing to do with the repair that we're affecting.
All right. So what about medications that you may see? So as you can see, antibiotics with aortic stenosis, aortic regurg, vasodilators, mitral stenosis. You can see mitral valve prolapse and mitral regurgitation. Notice that with mitral regurg, it's the same medications for atrial fibrillation, but also for congestive heart failure. Now, antibiotics are prescribed for endocarditis prophylaxis, which is uncommon but catastrophic. It usually develops in patients who develop bacteremia with certain organisms known to cause endocarditis. Transient bacteria can occur during certain surgical or dental procedures, so the patients have to be prescribed and on antibiotics prior to that procedure. Now, antibiotics prescribed in patients with valvular heart disease, prosthetic valves, or valve repair, if they have a history of infective endocarditis, congenital valve malformations, or rheumatic heart disease. Now, surgery. The procedure is based on the patient's risk profile and an evaluation of benefits. And as you saw during that American Heart Association video, there's two issues. One, which valve is it? And there's the access issue, and then which is primarily related to healing, and then there's the repair issue. So valve reconstruction, called an annuloplasty, ring-shaped device attached to the outside of the valve opening to reestablish the shape and the function of the valve. Prosthetic valve replacement, immunosuppression isn't necessary. So if you look at using either a mechanical prosthetic valve or a biological, you can see the advantages, pros and cons, and indications. So I've had patients that have had both. The mechanical ones are interesting because most patients were fine with it, but I had another one. And you could hear, especially if you put a stethoscope on the chest, you can hear tick, tick, tick. Every time the valve is closing, you can hear the noise. And that bothered, I remember one patient quite a bit. So at night when they were sleeping, they had to be given something to help them sleep, etc. Now, if we look at the prosthetic heart valve type, so you can see mechanical valve on the left, and these are different types of mechanical valves. You can see the pig valve. Yes, I've had patients that have had the pig valves, and then the cow valves. So what about the exercise prescription? So because valvular repair fits under the guidelines of cardiac rehabilitation, we'll go through those now. So this is from the ACSM and for outpatient. So as always, remember the frequency, intensity, and duration. What's important though is if you look at resistance training, I had a patient who was probably 50. He underwent a valve, either repair, replacement, I can't remember what it was. I normally in those patients, once I get them, they have to do 6 months aerobic exercise with no resistance training. And that's just a very conservative approach. Anyhow, following that, I wanted the patient to start resistance training. He made the comment saying that his surgeon told him he can't lift heavy weights. And I said, look, you won't be lifting heavy weights. And he said, look, I'll check with the GP. So he went back and I got a note sent with the patient GP and said, Dr. blah, 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 the surgeon, didn't want the patient doing any resistance training. And the patient wasn't happy about that because they were feeling fitter. Other patients with similar procedures were doing resistance training as part of their regime. And so I wrote back, I sent a thing to the GP, CC'd to the surgeon, basically citing the guidelines, et cetera, et cetera. You know, basically I got a handwritten note from the surgeon and said no resistance training, no explanation. So I don't know whether it was very complicated repair that didn't go perfectly or whatever. Anyhow, the patient was upset by it, and he ended up leaving the program and decided to go somewhere that he could do resistance training. Now, the exercise prescription. If there is no stress test information from a max test, then use RPE, where basically less than 12 is light and approximately about a 40% heart rate range. 12 to 13, somewhat hard, or equates to about 40 to 59%. 14 to 16, 60 to 80% of the heart rate range. Now, ensure all patients, clients with valvular heart disease undergo exercise stress testing by their cardiologist. They have to have a referral for exercise. Ideally, the referral will state aerobic and resistance training. So what a number of colleagues do is they make up their own referrals, and basically they want the GP to tick, or the cardiologist, but it's usually the GP, to tick which is appropriate. Unfortunately, GPs have software. Well, it's fortunate for them. Best practice or medical director, they push a button, it brings up a letter, and all they do is type, patient is fit to undertake an appropriate exercise program with Dr. Mike, or however they word it. So the problem with that is they're not specifically saying that the patient can do aerobic or resistance training, but they're not saying they can't either. So because the guidelines say that the patient can do blah, 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 then that's fine. It's when they send back your own referral and they've only ticked aerobic exercise that you then can't prescribe resistance training. So one of the things to do is, if you put your own referral like that, I highly recommend under resistance training you have light to moderate or something, so the GP knows you're not going to get them doing very heavy weights. Now, exercise is absolutely contraindicated if the patient has unexplained syncope. We spoke about that earlier in the lecture. A family history of sudden cardiac death, complex ventricular arrhythmias, long QT syndrome, or severe mitral regurg. So what about a study? This is early exercise training after mitral valve repair. So they used a cycloergometer at 70% of heart rate max from the first stress test. They did it for 3 weeks. Each session was 40 minutes, 5 minutes warm up, 30 minutes cycling, 5 minutes cool down. They did calisthenics, which were 20 different dynamic and isometric arm and leg exercises. And all sessions were under the supervision of a cardiologist. So they found that left ventricular ejection fraction slightly increased. So if we look at, they don't have it on this one. So VO2 increased by 4 mils per kg per minute. Really, that's measurement error. I mean, arguably 4 mils is nothing. So if we look at, they went from 16 to 20. So that's a 25% increase if we don't think it's measurement error. So, sorry, 22%. So that's actually quite good in 3 weeks. So the conclusion is exercise after a mitral valve repair does not deteriorate the outcome of the recent surgery. Mahalo. Thank you very much. This concludes this week's lecture. I'll stop now and I'll upload it to Blackboard for you. Thank you.